are in listen-only mode.
Good afternoon, and thank you for joining us today. The National Board of Public Health Examiners both hosts and sponsors webinars geared to explaining the certification in public health credential, the exam, and the future of the field. Today, we are pleased to welcome Dr. Joel Lee. He is the John A. Drew Professor of Healthcare Administration and the Director of the Doctor of Public Health degree program of the College of Public Health at the University of Georgia. Thank you so much for joining us today, Dr. Lee, and we look forward to your presentation.
Great, thank you so much. Welcome to all of those who've joined us. I'd like to start out by apologizing. I have an ear infection and I'm a little bit off my normal game, but hopefully everything will go well. I guess the key is on the right side of the screen, you've got an opportunity for chat where you can send messages. If you have any comments, if I'm speaking too loud, too soft, too fast, too slow, if you have questions or comments, please jump in. What I'm going to do as a way of organizing this material is break it up, as you'll see in a few moments, into several topics. At the end of each of those topics, I'm reserving some time for question and answer. So if you have questions, I can get to any of those questions as a group at the end of each section. So this is the first of the review sessions for this year's webinars. I know, having listened to some of the other presenters in the past, we each had different styles last year. I'm going to build into it some opportunity for questions I'll ask you. So I assume everybody has something to write with nearby, but if you don't, please grab a pen or pencil and a piece of paper. I'm going to ask you to answer a few questions at the beginning for your own use, and we'll repeat those questions at the end and see if you have the same answers or if you alternatively want to change them. I think that this area, health policy and management, is perhaps one of the more broad areas of the 5 core disciplines, and we'll try to get through this in as concise a way as we can. I do want to remind you, however, that rather than this being a 3-semester-hour core course in a school or program in public health, this is an overview of the information. In effect, this works like a topical outline. It'll help you assess what your strengths and weaknesses are, what you know, what you may want to go back and look at and learn more about. The other consideration I want to share with you is that I am teaching what I think is important as a faculty member who teaches this type of course. I'm not teaching what is absolutely certain to be on the examination. There is a panel of item writers that prepare the exam, and I do not have a copy of the exam in front of me, and I cannot anticipate all of the questions that those people might include. The goal in their preparation of the examination is to find a set of common questions that would be offered across curricula in all of the schools and programs in public health, and I'll explain how that's approached in a moment. So let me begin. Okay, there we go. Okay, so where is the content for the questions on the examination coming from? There are 2 documents that I think that are extremely important. In 2006, the Association of Schools of Public Health, now the Association of Schools and Programs in Public Health, had a comprehensive project identifying core competencies for the MPH degree. In the area of health policy and management, there were 10 competencies, and you can see those online. This information will be available for you after the session as well as today, but this is the array of topics that we're trying to cover today. Organization, financing, and delivery of health services in the public health system in the U.S., legal and ethical bases for public health, methods of ensuring safety and preparedness, the policy process, program planning, development, budgeting, management, evaluation, strategic planning and marketing, applying quality and performance improvement, systems thinking, how to communicate policy and management issues, and leadership skills. As you can see, that's a fairly comprehensive list. And to fit that into a one-semester course is a challenge, let alone trying to cover all of the material in a webinar over an afternoon. The second document was developed this past year, and it was developed for the National Board of Public Health Examiners, and it was based on, again, a group of faculty and practitioners involved with the core competencies. And again, this is available online as well as in my presentation. As you look at this, you'll see that there are some variations, but it's perhaps just a more detailed version of those initial MPH competencies. A description of the U.S. healthcare delivery system, which breaks it out into further detail than the initial competencies. Discussion related to access, cost, and quality of care. An addition that wasn't in the previous version in regard to global healthcare systems. The policy process is somewhat similar to the other document, management, leadership, and a set of specific components related to that. Human resources management, and finally financial management. So I've put together a presentation based upon those two documents. So going back to the MPH competencies, as you know, in preparing for the examination, there are the 5 core areas of public health. In addition to that, there are a set of questions related to what are referred to as the interdisciplinary or cross-cutting competencies. I think that in addition to the core nature of health policy and management, there's also content that we address in these courses to a lesser extent in communications, to a higher level the cross-cutting competencies related to leadership, professionalism and ethics, program planning, and systems thinking. So I'm going to be addressing those as part of my presentation. Okay, so the way we're going to proceed through this is into four organized units. The first one being systems thinking, second one focusing on health policy, the third one healthcare delivery systems, and the final one health management. So let's get started with a little quiz just as a way of assessing your knowledge, and then we'll be able to revisit these same questions, and I'll share my answers to the questions at the end of the session. So I'd like you to try to answer each of these 8 questions. I won't bother to read them out loud to you, and I'll give you about 15 or 20 seconds for each one if you'll read through it and make note of an answer. I hope that's about the right amount of time. Let me go to the second one, about 15 seconds for this one. Okay, the third question. Fourth question. Fifth question. Sixth question. Seventh question. And the final question. Okay, great. And as you know, the questions on the National Board exam are all objective questions rather than open-ended questions. I hope I've given you enough time to read through them and answer them. You're working much more at your own pace when you sit for the examination. By the way, I should mention I am a CPH. I have taken the exam and successfully completed it. So what we're going to do is, as I mentioned, is start out by talking about healthcare systems, but to put everything in perspective, is a good example. The National Academy of Sciences Institute of Medicine talked about the future of public health in the 21st century. And some of the key things they talked about are listed on that slide: a health policy that assures adequate and sustained investment in the important determinants of health, a strong governmental public health infrastructure, and a public health system that reflects public understanding that health is everyone's business. Okay, so how do we create a system to address this? And I've thought about this a number of times, how to jump into the topic of systems. And some of you may have owned this game when you were kids, the mousetrap game, where there's an illustration on the screen now of something. This is a three-dimensional plastic kids game that really reflects systems thinking. If you look at the center of the page, there's a crank that's labeled letter A. And when you turn that crank, the yellow portion rotates the red portion, which trips the lever that's attached to it, causing boot D to kick a bucket, which a marble falls out of and rolls down the steps, continuing on into the track, hitting pole H, which pushes a bowling ball into the bathtub. After it spins around a while in the bathtub, it drops out the drain, hitting a diving board, and the man who's standing on the diving board falls into a tub of water, which then shakes the basket that's at the top of pole P, falling down on the mouse. And if you owned that game when you were a kid, one of the problems was always that something would go wrong, keeping that final step from occurring. So this was a system where each piece was interdependent on the other components of the process. Otherwise, it would not possibly trap the mouse. So I think that's a good way of starting out with systems. Let me give you some examples, and I think that if you listen to the other webinars in the series, you'll hear examples of systems in other disciplines of public health. The social and behavioral sciences certainly have systems. Environmental health certainly has systems. I'm going to start out with some general examples and then go to some much more specific examples. In terms of health and well-being, in this illustration, as you can see, there are a variety of factors that influence the individual at various levels. Oops, I'm sorry. As most of you are probably familiar, the World Health Organization definition of health is a state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. As you can see in this illustration, there's a model that describes factors, again, that are part of the system external to the individual. We can focus in a bit more on those. Culture of the external environment, the community the individual lives in, factors related to lifestyle influencing personal behavior and psychosocial environment, their work environment, which again has psychosocial and physical aspects, self-care system, personal behavior, and human biology. The impact of family, and once again that has specific aspects of the individual in mind. So we have this system where if all things are in balance, we're going to see somebody in obviously better health than alternatives. Okay, in the healthcare system, we have a fairly complex set of processes. Some people say that it's based on lack of organization in the healthcare system of the U.S., other people potentially say that we couldn't just randomly have what we have. It's part of a carefully planned system. It's probably a little bit of each. So in the U.S. healthcare system, we have a number of factors that are influenced by both external environment of government and the private sector in terms of technology, in terms of clinical professions that influence the well-being of individuals. I think one of the best ways to talk about the system is to try to look at it in terms of these three content areas: cost, quality, and access to healthcare services. Each of those is clearly important. I think that we can go on without defining those. If anybody has any questions about them, certainly when we get to the questions in this section, please ask and we can go back to that. In terms of comparative health, as an example of cost and quality, I'll let you read this cartoon on your own and then I'll make a comment. There's a balance between the issues of the cost of care and the quality of care. There's also an overlaying issue of who gets the care in terms of access. Is it widely accessible to all people or only selected individuals? So that's another example of a system. Urban versus rural healthcare. I suspect some of the people on the conference call live in rural areas, others in urban areas. The way healthcare is organized and delivered in those two settings is obviously very different, defining different systems. Excuse me. In terms of talking about a system of quality, Avedis Donabedian's model talks about an external environment, and you can see the various components in the slide of the external environment, which are typically beyond the control of either the individual or a healthcare provider. What we do have greater control of are those three components that follow: the structure, the process, and the outcomes of the delivery system. And in most systems, we always have an opportunity for feedback to refine the process over time. Here's an example of another system. I wouldn't even try to guess how to explain this one. But, you know, once again, we have interacting activities of a very complex delivery system. I think a more manageable approach is this illustration. This is from a management textbook that some of you may have used, authored by Rakic, Longest, and Dar. Again, it looks at the external environment to a healthcare organization. If you look at the top row, there's a general environment: ethics and law, politics, culture and sociology, public expectations, economics, and the ecology. At the bottom, you can see much more specific healthcare factors in regard to public policy, competition, healthcare financing, technology, research and education, health status and health promotion, and public health. All of those are external factors that influence the organization and how it functions. Within that larger box, we can look at the organization, whether it's a public health department, a hospital, a long-term care facility, and so on. And we can look at inputs to the system, the various resources that are available. We can look at the conversion of those resources, and the key components related to that are the organizational structure, the human resources, the people involved, and the specific tasks they are seeking to accomplish and the technologies they have available to do so. And all of that leads to the outputs of the process. What are the results? How do we accomplish various activities? Once again, there's an opportunity for continuous improvement through refinement. The feedback allows us to make changes within the organization to improve our performance. It's less likely to have a great deal of influence on the external environment, those top and bottom rows. Okay, another example, based on resources, we could define systems based on the personnel, their training, their availability, the financing of the system, how do we pay for care, the availability of technology and supplies, the availability of facilities. And we could certainly make develop a different description of a delivery system model if we look at the typical U.S. model, or if you've been watching, the various news broadcasts talking about Ebola in Africa. What's the availability of personnel? What's the availability of finance? What are the resources in terms of technology and supplies? Are facilities available? So the delivery system is better defined in terms of resources in this model. Another way, one of the things that we read about in terms of content is stakeholders. Here's the Institute of Medicine model describing what a public health system looks like, identifying a group of stakeholders in the process. Who has a vested interest in these activities? CDC has developed a model for the 10 essential health services, public health services, and we'll come back to this one a little bit later. The external ring is their 3 functions of assessment, policy development, and assurance. Within that, they have those essential components under assessment: monitoring health, diagnosing, and investigating; under policy development, inform, educate, and empower, mobilize community partnerships, and develop policies; under assurance, enforcing laws, linking to or providing care; assuring a competent workforce; and evaluations. And this is a continuous process which leads to the management of the system and the most central area of developing research to improve the activities. So all of these are approaches to systems, each one slightly different. Let me pause at this point, and if anybody has a specific question they'd like to ask right now, feel free to type it in on the message bar on the right. And I'll wait a moment to see if there are any questions. If there aren't, we'll just move on. Erin, I don't see any messages. Is that correct? I think we may have lost Erin, but I don't see any questions. So we'll have another opportunity a little bit later if you do have some questions about systems. Okay, I built. I'm sorry. Go ahead.
Yes, you are correct. There are no questions other than when will the slides be available, and we are recording this presentation, and we will archive it on our website. It should be up mid-next week at the latest.
Great, thank you so much. You must have been on mute. Okay,
yes.
we're only in about 25 minutes at this point, so I had saved some space for a break if we needed it. I think we'll just keep going for a while longer, take a break maybe at 3 o'clock. Okay, so continuing on, let's talk a bit about health policy. Again, it really does become a system. The interrelationships that exist focus on formulation of policy, implementation of policy, and then finally modification and refinement of the policy that's been established, and we'll be using some examples to elaborate on that in a moment. Public policy is important because we're responding to the needs of the general population, who may or may not understand some of the issues that are being confronted in policy development. I'm particularly attracted to this poster at this demonstration, Keep Government Out of My Medicare. I think that whoever prepared that poster fails to understand that Medicare is a federal government program, and it probably would be defined as a social program. So, understanding by the public is an extremely important issue related to the services we're talking about. So what's the legal basis for what we do in public health? U.S. Constitution. People frequently refer to the preamble to the U.S. Constitution, where it refers to promoting the general welfare and securing the blessings of liberty to ourselves and our posterity. The courts have had difficulty saying this legitimates healthcare activity, that the Constitution doesn't use the word health. So where's the basis for federal activity? It tends to fall in the Commerce Clause of the U.S. Constitution. The Constitution gives Congress power over trade activities among the states, with foreign countries, and with Indian tribes. So Native American tribes are included in this process. Article 1 refers to the power of Congress to regulate commerce across those groups. And commerce is usually interpreted in a very broad way to mean business or commercial exchanges in any or all forms between citizens of different states, including nations. So Congress has the authority to implement policy under the Commerce Clause. As an example, Section 361 of the Public Health Service Act, which authorizes the Secretary of the Department of Health and Human Services to take measures to prevent the entry and spread of communicable diseases from foreign countries into the United States and between states, is based upon the Commerce Clause of the Constitution. And my illustration is looking at immigration into the United States at the early part of the century. But anybody who's traveled outside of the United States in the past few months, on their return, has been asked questions about whether they've been in Western Africa, whether they've been exposed to any individuals who have Ebola, and then the decision of what to do in regard to somebody who may have been exposed to a contagious disease is authorized under this law. Something more complicated is what I suspect most of you have been watching at a more broad level, the Affordable Care Act. Under the Commerce Clause of the Constitution, in 1824, Chief Justice John Marshall referred to the fact that Congress's power to regulate commerce may be exercised to the utmost extent. In June of 2012, when the Affordable Care Act reached the Supreme Court of the United States, now Chief Justice John Roberts Jr. ruled that the health care legislation was constitutional, but not based upon a broad issue of health, but on Congress's authority to tax, because that's clearly a component of the legislation. In stating that, he went a step further and said he rejected the widely held expansive view of the Commerce Clause that rules out Congress's power to require individuals to purchase insurance, or for that matter, eat healthy foods. So we now have another provision of the Affordable Care Act reaching the Supreme Court, and we're going to see how the Supreme Court again interprets that. So the basis is on the members of the Supreme Court interpreting the U.S. Constitution. Okay, so the more specific aspects, when there is a specific decision made for implementation of a statute or law, what are the categories we have? And we can talk about criminal law, the conduct that's prohibited by government because it threatens or harms public safety or welfare. Environmental aspects of public health may be a good example related to criminal law, dumping of toxic substances. Civil law is referring to the actions that are intended to protect the public health and welfare. Perhaps as an example, an expectation for immunization of school-aged children. Third category, police powers. The Constitution of the United States provides police powers to allow regulation and behavior, again under the Commerce Clause, that relate to the betterment of the health, safety, morals, and general welfare of inhabitants. It can also be used to encourage specific behaviors, taxes on tobacco. There can also be coercive actions, the quarantine we've already referred to, seizing property that may be harmful to the public, or local level, a good example might be restaurant inspections. A restaurant that fails to meet the code in terms of sanitation may be closed until they bring their facility up to expected standards. The laws are, they can't address every component, so another aspect in addition to law is the administrative aspect of regulation. Usually laws will provide for regulations to be written by appropriate departments or agencies. So what we can do is have a law which states at the federal level the authority for the Secretary of the Department of Health and Human Services to establish regulations to implement the law. So in doing this, here's a nice little checklist that I found describing the policy analysis process. Why do we develop laws? We have a problem. So in developing a problem statement, what would you do? Can I identify the focus of the problem? Can I identify options for solving it? What's the background? Does my background include all of the necessary factual information? Have you been able to eliminate any information that's not directly relevant? Is it an appropriate tone? Landscape, in the previous section when we were talking about systems, I talked about external environment. I think we're talking about the same thing here. Does the landscape identify all of the key stakeholders? Are the stakeholders' views clearly described, clearly accurate? Is the structure of the landscape consistent and easy to follow? Is the tone of the landscape appropriate? Does the reader have the information necessary to assess the options that are available? Okay, and then we get to the options. Do my options directly address the issue identified in the problem statement? Can you identify the pros and cons, the positives and negatives of each option? Did I apply all of the criteria to each option? Are the options sufficiently different from each other to give the client or stakeholder a real choice? Are all of the options within the power of my client? And then finally, the recommendation. Excuse me. Is my recommendation one of the options assessed? Did I recommend only one option? Did I explain why this recommendation is the best option despite its flaws or limitations? Okay, and here's a graphic that basically addresses the same types of issues as in our systems examples. You can see at the top and bottom of the page there are external environmental factors and opportunities for feedback in the process of formulating and implementing policy. Okay, so let's go on to some implementation. In some ways, you know, this is what people do in 6th grade in the U.S. And I should comment, if there are any international participants in the webinar, the exam is clearly focused on U.S. Policy and governmental structure. So I'll point out some examples of sites where you may be able to address the questions talking about the U.S. structure in a moment, but as everybody knows, there are 3 branches of government. If you'd like to understand a bit more about how Congress approaches health care, here's a nice YouTube video which is available, just about 30 minutes, which will help you gain an appreciation of that process. The details of the process, how a bill becomes law, the same set of activities is occurring in the House of Representatives and the Senate, where there's introduction of a bill by one or more members of the House or the Senate. The bill is read and assigned to a committee for consideration. The committee reviews the bill. It may hold public hearings on it. They'll debate it. They may amend it, modify it in a variety of ways. Ultimately, it's voted on at the committee level. If it's approved by the committee, it then goes to the House as a whole for consideration. Again, there's a possibility of amendment. In the event the House passes the bill, it's sent to the Senate. The same process would be occurring on the Senate side, and it would be sent to the House. It's unlikely in many instances that the final product that's approved by the bill as a bill in the Senate or in the House would be identical. And that's the reason we frequently would have a conference committee consisting of members of both the Senate and the House of Representatives trying to resolve those differences. I should also reiterate, the term bill talks about proposed legislation before it becomes law. Okay, so let me jump to the next one. Oops, I'm sorry. Sorry about that. Okay, so ultimately we're going to either have consensus on a bill which is then approved by both the House and Senate, or the legislation, as it might have at any of the other stages, dies because there's a lack of consensus. Following approval, it's obviously sent to the President. Options 1 and 4 are most likely. The first option is the President signs the bill and it becomes law. The fourth option, the President vetoes the bill. At that point it dies, or alternatively it requires a 2/3 vote each in the House and the Senate. The one that's receiving public attention right now is the Keystone Pipeline, and whether that will not only receive approval in the House and Senate, but whether the President will veto it and there will be sufficient supporters for a 2/3 vote in both the House and Senate. Option 2 talks about what happens if the President does not sign the bill and does not veto it. After 10 days, when the Congress is in session, it becomes law even if the President does not sign it. Option 3, in the event that the Congress is not in session and the President does nothing, does not sign it or veto it, it fails. So the timing of the legislation also becomes a component. Okay, once the law is implemented, as I said, the administrative component of regulations assigns responsibilities for a variety of activities to an executive branch of government. Here's an organizational chart for the U.S. Department of Health and Human Services. So the law may authorize the Secretary of the Department to implement specific aspects of the law, and you can see the variety of entities: Food and Drug Administration, the Centers for Disease Control, the Agency for Healthcare Research, the Centers for Medicaid and Medicare, the Indian Health Service, the National Institutes of Health, and so on. We tend to think most frequently about the Department of Health and Human Services being the focal point for healthcare activity in the U.S. And in reality, there are many other branches of government that are engaged. As examples, in terms of cabinet-level departments, the Department of Agriculture, the Department of Commerce, Defense, Education, Energy, Housing and Urban Development, Interior, Justice, Labor, State, Transportation, Treasury, Veterans Affairs, all have engagement in healthcare policy and its implementation. There are additionally a group of independent federal agencies which are on that slide: Medicare Payment Advisory Board, Federal Emergency Management Agency, the Consumer Product Safety Commission, that might also be authorized under law to be engaged in the implementation of legislation. Okay, so several examples of some key legislation. We won't go through all of these, but going back to 1798, the U.S. Marine Hospital Service was established, and it was one of the first public health activities is a means to provide healthcare services for merchant marine returning to the United States on ships who may be carrying contagious diseases. So that again goes back to the issue we've discussed in regard to the Commerce Clause. 1918, we saw the first federal grants to states to provide public health services. And although there's not an arrow at it, I'm going to speak to it in a moment. 1935, the Social Security Act was enacted. So jumping ahead, a couple others that I think are important. The Pure Food and Drug Act in 1906, addressing safety of food and cosmetics. The Clean Air Act in 1963. Social Security Act, as I was mentioning, is important. One of the refinements when we were talking about feedback earlier in systems is what happened in 1965. In 1965, we saw enactment of Titles 18 and 19 of the Social Security Act. Title 18 established the Medicare program for people over the age of 65. And disabled individuals as well. And Title 19 addressed Medicaid, which provided benefits for low-income children and their caretakers. So we saw a refinement of the intent of that legislation. I haven't put an arrow next to it, but as you'll note, in 1997, we saw the Children's Insurance Plan, which became Title 21 of the Social Security Act. So we see this continuous evolution in the system of refinements. So if we look at the roles of presidents of the United States in this process, under Roosevelt we saw Social Security. Under Johnson, we saw Medicare and Medicaid implemented. Under President Obama, we've seen healthcare reform. Okay, so in terms of healthcare reform, and again, remember there are a limited number of questions on this exam, so there aren't going to be 40 questions about the Patient Protection Affordable Care Act. But you do need to understand some information about it. Once again, as a way to expedite our process today, rather than going into elaborate detail, I have a URL posted on this slide to a very nice little YouTube animation that's only about, as I recall, about 8 minutes long, 8 or 9 minutes long, that gives a nice overview of the Affordable Care Act. Okay, so earlier we referred to stakeholders. And I think that an easy way to think about this is to categorize them into these 4 groups. I think there are a variety of ways to subdivide them, and I'll give you some examples in a moment. Most important to us, lower right-hand corner, the consumers of care, the patients. Perhaps on the top left, the providers, the doctors, nurses, other healthcare personnel involved in offering services to our patients. Who pays for care? There's a role for employers in the process. There's a role for insurance companies. And I think one of the important things is, as individuals, stakeholders do not have a great deal of influence on the system. As organized groups, they potentially do have substantial influence. Let me give you some examples of that. As organized groups, associations of physicians and nurses play a role in defining the responsibilities of their profession. And we'll talk a little more about the profession of public health later in my discussion. Cooperatives, including activities like health maintenance organizations that provide service to membership. The role of government, how we influence the election of the people who represent us. Frequently, organized religion plays a role in this activity. Employers, investors in the stock market, unions looking out for the benefits of their members, and philanthropists, people who have the ability to contribute large sums of money for various activities. So we always want to look at who the stakeholder groups are and how they might be influencing the system. Okay, so let's jump a little further into this by talking about ethics. We're never going to have enough resources available to provide unlimited services for all people. So it's a question of how we're going to divide the pie. I think there are a series of models, as you can see they're listed here. Do we give every individual an equal share of the limited pie? Do we say we're going to give more pie to those who've gone without pie in the past? Are the more powerful people going to receive more pie where the people with less influence are going to receive less pie? Those who make the greatest contribution to making the pie should get the most pie. Go back to the equal shares model, but say let's have equal shares for everybody unless there's a special case. Or finally, those with the greatest need get the most pie. It's a decision in regard to policy and ethics, how we're going to allocate our available resources. Okay, so in terms of professional ethics, one of the things that I think is important is most professions have a code of ethics. I don't know how many of you are familiar with the code of ethics for public health, but we're going to talk a little bit about a public health oath in a moment. Code of ethics makes it clear to the population and our communities what our ideals are. It helps us by creating a goal and a standard for the activities that we're involved in public health. And it helps us to untangle complicated issues. Okay, so some of you, I know a number of the participants in the session are current students or recent graduates. Some of you probably as part of an orientation session to your public health degree or as part of your commencement ceremony participated in the public health professional oath. And just reading through that quickly, as a public health professional, I will hold sacred my duty to protect and promote the health of the public. I believe that working for the public's health is more than a job, it's a calling to public service. Success in this calling requires integrity, clarity of purpose, and above all, the trust of the public. Whenever threats to trust in my profession arise, I will counter them with bold actions and clear statements of my professional ethical responsibilities. That starts to help to define things. I'm sure everybody on the call has had somebody they know ask them when they talk about pursuing education or careers in public health, what is public health? I think that this helps explain it to many people. I do hereby swear and affirm to my colleagues and to the public I serve that I commit myself to the following professional obligations in my work as a public health professional. I will strive to understand the fundamental causes of disease and good health and work both to prevent disease and promote good health. I will respect individual rights while promoting the health of the public. I will work to protect and empower disenfranchised persons to ensure that basic resources and conditions for health are available to all. That's getting back to how we slice the pie. I will seek out information, use the best available evidence to guide my work. That certainly relates to policy. I will work with the public to ensure that my work is timely, open to review, and responsive to the public's needs, values, and priorities. I will anticipate and respect diverse values, beliefs, and cultures. I will promote public health in ways that are most protect and enhance both the physical and social environments, going back to systems. I will always respect and strive to protect confidential information. I will maintain and improve my own competence and effectiveness. So I think that helps define what we're talking about in terms of a standard of ethics for the profession. Going a step further, some of you who've been involved in research activities have needed to respond to an institutional review board, which was established as a requirement under federal law and regulation to protect individuals who are research subjects. And the key document related to that activity is the Belmont Report. It has 3 core principles. The Belmont Report indicates that We should demonstrate respect for persons, and as many of you are familiar with the Tuskegee research and other events which may have violated the trust and protection of the research participants. This is saying, first, we have to respect individuals, protecting the autonomy of all people and treating them with courtesy and respect, allowing for informed consent. Researchers must be truthful and conduct no deception. So many of you have been involved in something where you have to sign an informed consent form. The second category, beneficence, the philosophy, do no harm, while maximizing the research project and minimizing risks to the research subject. And the third one, justice, ensuring reasonable, non-exploitive, and well-considered procedures are administered fairly, the fair distribution of costs and benefits to potential research participants, and demonstrating that all will be done equally. Some of the primary applications: informed consent, assessment of risks, assessment of benefits related to the research activities. Okay, so that wraps up policy. We're just about at the hour point. Let me ask if there are any questions that I can answer at this stage.
It looks like I've answered all the questions. They've been mostly about where the presentation will be archived and how they can get it. If you do want to address one question we had about the quiz, when we're going over the answers for that.
Right, at the end we'll go back to those.
Okay.
We'll do two things at the end of the session. I'll repeat the questions so that you can see if you want to change your answers to any of them, and then we'll talk about the answers.
Great.
Okay, great.
Great.
So, I'm sorry, Erin, go ahead.
Oh, and I was just going to say, I shared with everyone the links to the ASPPH YouTube page, as well as the National Board of Public Health Examiners page, where the webinars are going to be archived.
Outstanding. Thank you so much. It's about 2:55. How does it sound if we take a 5-minute break and we pick up at 3 o'clock?
Sounds great.
Great. So we'll start promptly at 3.
Okay. Talk to you soon.
Thank you. Okay, I guess we're back about 3 o'clock now, so let me pick up.
Dr. Lee, before you get started, there is one
Yes.
question.
Sure.
The question is, who is in charge of the administrative regulations and how are they assigned to health agencies?
Oh, good. Okay. Before we go on, let me talk real quickly about that. Normally, in a bill, it will say regulations promulgated or established by, and it'll identify the Secretary of the Department of Health and Human Services as an example. It's my impression that one of the complications related to the Affordable Care Act is rather than creating those opportunities for regulation, the Affordable Care Act is as lengthy as it is because Congress tried to write all of the details into the law instead of writing a short law which would be implemented through regulation. The alternative occurred, and I think that was because people were suspicious of each other and wanted to assure that their personal, objectives were implemented through the law. It was written in detail. But normally, laws will provide, and the same thing happens at the state level, by title, not by the individual's name, but by title, to be established by the following person in government. And I can add to that there's a formal process related to regulations where the draft regulations are made public for comment and then refined based on the public commentary. So I hope that answers the question. If not, feel free to do some follow-up, but it's usually built into the law.
Thank you, Dr. Lee. There is also a question, if I could repeat the quiz questions that have gone through, and I've copied those questions again, and I will post them and send them to the participants just in case.
Sure, and I'll show them again at the end of the session. When we answer them, we'll revisit them.
Great.
And what I'm going to do is give everybody an opportunity to think about whether they want to change their answer based on what we've been doing the past few hours. Okay. So let's go on, and we'll talk a little bit about the delivery system and how the continuity of care is established. Okay, so we're all in public health. We're going to be public health providers. How does this work? Interestingly, I think that most people think about public health being an activity of government, federal government, state government, local government in the form of cities or counties. But there's a significant component of public health that's assumed by the private sector, and many graduates of the schools and programs in public health are employed on the private side. So, we can certainly look at these activities in terms of government responsibilities. I think that frequently people see it as being invisible until there's a need. We assume we have safe, available drinking water until a point where it's not available. I think that fire departments and public health departments share an issue that they aren't noticed until they're needed, and it's hard to prove a negative. Okay, so private sector has great responsibilities, as I mentioned. Public health agencies, including the graduates of the schools and programs. Let's look at some of the things schools and programs talk about as governmental responsibilities. Here's a CDC list of the top 10 achievements of public health. Vaccination against communicable disease, motor vehicle safety, safe workplaces, control of infectious disease, decline in deaths from coronary heart disease and stroke, safer and healthier foods, healthier mothers and babies, family planning, fluoridation of drinking water, recognition of tobacco as a health hazard. I think that the people who ask you what you're doing in public health, those are some examples of the successes that you might note what public health has done for the population. Obviously, we think about public health at the federal level. Centers for Disease Control is just about an hour and 30 minutes from where I'm located right now, so our students certainly think about CDC as a potential employer of graduates. If you want to get a better feel for the federal role in public health, I encourage you, when you have time, to watch a movie that was made in 1950 called Panic in the Streets. It talks about an outbreak of pneumonic plague in New Orleans. In the picture you see Richard Widmark, who's a U.S. Public Health Service officer, and Edmund O'Brien, who's a local police officer, trying to track down issues related to both criminal and infectious activity in New Orleans causing this problem. You can download, it used to be on YouTube, and for copyright reasons it's no longer there, but for several dollars, I think it's about $2.50, it's available at Google Play and iTunes, and it's worth watching. In addition to the federal activity, we certainly have the state activities. State activities are far more detailed, far more broad than the federal responsibilities related to public health, and that's one of the things the movie Panic in the Streets tries to clarify. And then, of course, local health departments, multi-county, county, city health departments, which take on a set of specific responsibilities. Okay, so let's talk about the resources, the money related to this. The bad news, as you can see, is the cost of healthcare continues to rise. The good news is this year we had less inflation in healthcare costs than was anticipated. But I can remember when I was working on my master's degree, one of the faculty members told me that if the percentage of gross domestic product allocated to healthcare in the United States ever rose above 10%, it would probably cause government to fail. So we're now in the 19% range, and we're still going strong. Okay, so let's take a look at the sources of funding for healthcare activities. As you can see in this illustration, private health insurance is paying almost a third of the costs of health care for the citizens of the United States. Second largest payer is Medicare, followed by the Medicaid and CHIP programs. Out-of-pocket payments, people who just pay cash for services, that represents 11%. There's other types of private spending, and there's other types of public spending. In 2010, the national health expenditure was $2.6 trillion. We always have a little lag in these numbers. Okay, 2012, where did the money go? Largest expenditures went into inpatient care in hospitals, 31%. Physician and clinical services represented 20%. Other professional services, things like physical therapy, another 7%. Residential and personal care, long-term care services, and so on, you can see represent components. Pharmaceuticals, 10%. I'm just trying to think what else is important. Health insurance. So you can see that hospital care is the most expensive component. Obviously, if public health activities are successful, it's going to keep people out of the hospital in some instances or reduce their length of stay, and that's going to have a significant impact on healthcare spending. One of the interesting trends that is taking place in the past year is hospitals employing somebody with the title Chief Population Health Officer, looking at a variety of activities that are more broad related to public health than their traditional acute care. Okay, so where does public health fit into this? Of all the activities we're looking at here, 1% of all healthcare expenditures in the United States are allocated for public health activities. Where does the money come from? 41% comes from state funding, 32% So about a third each, a little bit more than a third state, a little bit less than a third federal funding, something in the range of 10 to 12% for fees and reimbursements and local funds, and then some other sources we're less familiar with. Okay, and I debated whether I should go into this detail, and I decided I'll do it relatively quickly. There is money that, in terms of the policy, is authorized in legislation, saying that Congress allows up to a certain amount of money to be spent on a particular piece of legislation. But separate from that, Congress must approve appropriations allocating money on an annual basis for those purposes. Even though we say that we're going to spend money on something, unless there's an appropriation, funds are not available. And if you'll recall, about a year ago, we had the absence of an appropriations bill that had been passed by Congress, and as a result, government shut down for, I can't recall the exact number, but I want to say about 13 days where federal employees were furloughed and they were not in essential roles. So the Omnibus Appropriation Bill in 2013 was the most recent detailed appropriation. The 2014 bill that was passed continues funding at this level. So what are some of the things that were in there? Funding for the Affordable Care Act was in there. It made specific provisions in terms of the allocation of funds, but also there were some cuts in what the original authorizations were. As an example, there was a cut in the Prevention and Public Health Fund by $1 billion. So the chairman of the House Appropriations Committee said $1 billion would prevent the Secretary of Health and Human Services from rating these funds for Obamacare exchanges. So the concern of a senior Republican was, if we make this funding available, it will be used for purposes other than what we intended it for. And as a result, they reduced not the authorization, because that was already in law, but the appropriation. Okay, and there are just some details, and I think we can skip over these. But this is just an example of how money is appropriated to implement the legislation that is currently on the books based on its enactment. Okay, so let's talk a little about personal health care and some terminology. I think as public healthers, everybody is familiar with the terms in terms of preventive care or health promotion activities. What are we going to do to prevent the occurrence of healthcare problems? What are we going to do in regard to improving the health of the population? Primary care. These are outpatient services. When you visit a physician's office and you go home afterward, we're seeing a growing number of what I have as an example, walk-in clinics. There's some discussion that Walmart could become the largest healthcare provider in the United States in regard to primary care by establishing walk-in clinics in all of its store locations. Walgreens is also becoming involved in walk-in clinics, which are going to be no appointment acute care visits. Hospitals, secondary and tertiary care. Inpatient care. Hospitals are licensed to provide the services they provide. Patients reside in the hospital receiving both medical services and hotel services. How do we divide those things up? And here's a little chart that talks about some of the terminology, and one of the questions that I asked initially addresses this. We can divide the organization of healthcare services into both private non-governmental ownership and government ownership. In the private sector, we can talk about voluntary and investor-owned facilities. Voluntary talks about not-for-profit, and while you don't need to recall this in all likelihood, Section 501c3 of the Internal Revenue Service Code defines the criteria to be a not-for-profit organization. In addition to that, we have investor-owned, usually owned by individuals or through corporate stock, where there's an expectation that the investors receive a return on their investment, that they get money back for investing. So the difference is voluntaries, and I've got a slide in a moment that speaks to this. There's some people use the term nonprofit rather than not-for-profits. I think that you must use the term not-for-profit because if they're not generating surplus revenue, they don't have money for renovations or replacement of equipment or other activities. So it's how the money is used rather than whether they receive more money in income than the expenses associated with their operation. Investor owns can use that surplus revenue to compensate their investors. Okay, so under the voluntary category, we typically see two groups. Sectarian, the religious-based organizations, and many religious denominations operate healthcare services. Frequently, it's in the name of the hospital. The non-sectarian are community-based organizations, other activities. The Shriners Hospitals is an example, where they are not affiliated with the religious denomination. They are categorized as not-for-profit. On the investor-owned side, we see individual owners. There are some hospitals that are owned by one person or a partnership of several people, or a corporation that may own 101 hospitals. So we have the same thing in hospitals and other settings. We'll talk in a moment about long-term care nursing homes. The same thing might apply. In terms of ambulatory care, the same thing might apply in terms of ownership and operation. The government category, federal government operates a variety of very large healthcare systems. The Department of Defense operates facilities that serve both the members of the military and their families. Department of Veterans Affairs, over the past year we've seen a lot of attention about the quality of services in VA hospitals. Historically, and I think still the case, while there have been these exceptions with severe abuse, the quality of care in VA facilities has been quite good in recent years. U.S. Department of Health and Human Services operates facilities as well. Department of Justice provides health care in prisons, federal prisons. State level, we see a variety of specialized hospitals, including psychiatric facilities. Some of you are primarily located in academic health science centers, where your public universities are state universities, and there's a relationship to the state government. Local facilities can be hospital districts that are defined by government or public health districts or authorities, county agencies, city, county, or city agencies. Okay, elder care. I love these two photographs. I always try to decide what game the two individuals are playing. I think they're bowling, but I'm not sure. Maybe they're playing tennis or something. In terms of an aging population, we have a variety of services which require our support. People typically think of traditional nursing homes, but we're seeing a variety of other activities in terms of visiting care in the form of home health, senior living communities, retirement communities. But clearly the long-term care demand is growing with an aging population. Okay, so a little bit more about payment. Fee-for-service is a key term. You pay when you get a service based on what you receive. What I think about is an equivalent. Last week I had some work done on my car. When I drove in, I could ask them, how much is it for an oil change? And they would tell me the exact amount for that service, or to buy a new tire or whatever it might be. And at the conclusion of providing that service, they would expect me to pay for that service. In contrast, we've seen more and more people, and some of you probably participate in managed care activities, health maintenance organizations. That model, rather than paying on a fee-for-service basis, people are capitated where you pay a flat fee in advance for your services. You may use services, you may not use services, but you're assured coverage for all of your benefits. In an HMO model, there are incentives financially to keep people healthy in a variety of models to reduce their use of more expensive services such as hospital care. The largest criticism of this type of model is that somebody who requires medical service for financial reasons will be denied access to that service. In terms of the global component of the criteria we talked about at the beginning, here's an example comparing the United States at the bottom of the page to a measurement of health status in other industrialized nations. This was done by the Commonwealth Fund last year. We're very expensive, but when you look at the outcomes, we're not competing very well with other industrialized nations. There are a lot of components to explaining that, but the bottom line is we are seeing a significant difference. In this, again, Commonwealth Fund measure, it's ranking the industrialized nations based upon their overall performance. Once again, you can see of the 11 nations in the table, the U.S. ranks last overall. We do better in some areas. In terms of effective care, we rank number 3. In regard to the efficiency, equity, and healthy lives in the United States, again, we rank last. If you look at the cost of care in the nations, you can see Australia, the average cost per person is on an annual basis $3,800. In the United States, we're expending over $8,508 per individual. So one of the questions we continuously return to is, are we getting what we're paying for? How can we get greater value and improve the outcomes related to the U.S. healthcare system? I guess one other that I should point out that, we rank in the middle, but we're doing much better in terms of timeliness of care than some of the other nations. The waiting lines are shorter in the U.S. Okay, so that's an overview of some of the delivery system issues. If you have any questions, I'd be happy to help with that.
Yes, Dr. Lee, we have a question. What would motivate secretary and organizations set up hospital NGO? Do they get tax exempt from government? I would imagine their expenses might be high on there if they don't make any profits.
Okay, why would somebody be not-for-profit? It's based on their mission. I think the first thing is that when you look at the organizations that are classified as not-for-profit organizations, their mission is to provide a service to a defined population. It may not be the entire population, but a specific population. It may be children. Probably anybody who's turned on a TV set in the last couple weeks has seen some sort of commercial for, I just went blank on the name, Danny Thomas founded the hospital in Memphis for children. Forgive me, I just went blank on that. It's a service or
Miracle Network.
No, that's a funding entity. But St. Jude's, thank you.
Yes.
Which is a not-for-profit facility which has a very clear mission of service rather than return on investment for its founders. There are some considerations, and this may be getting into a little bit too much detail. For-profit organizations, under the Internal Revenue Service Code, have to pay taxes on their profits. Not-for-profits don't pay taxes on their profits, and they can simply reinvest that money into the services they provide. So there's the advantage that they're exempt from tax. There's one other benefit under the Internal Revenue Service Code, which is individuals who want to make donations to a not-for-profit organization are able to take a tax deduction on their personal income tax based upon that contribution. So if you wanted to donate money to a for-profit organization, they'll be happy to take it, but there's no benefit to you or the population served by the organization. I hope that helps clarify it a bit further. Anything else?
No, I think that's it for right now.
Okay, great. Okay, so we're getting to the final section now. I think we can skip this break. It's about a half hour since the last one. Let's talk a little bit about management. And when people talk about management, there's a concept called the 5 pillars. And as you can see, service quality, people, finance, and growth are the 5 pillars. So let's talk a little bit about it. Clearly, there's a component for leadership. How do we motivate people? How do we organize activities to perform at their highest level? Some of you may have taken an introductory management course at the undergraduate level. In many of the master's programs, you'll have talk about this, but the basic focus in a college of business is around the functions of management. How do you make decisions? And the components associated with that start in the upper left-hand corner. Planning, deciding in advance what you're going to do. Organizing, developing intentional patterns of relationships among people and other resources. Staffing, acquiring, maintaining, retaining human resources. Directing, initiating work in the organization, usually that's in a supervisory role. And controlling, regulating activities in accordance with your plans. And that also creates an opportunity for the feedback. So those are the key 5 functions of management. In terms of implementing those 5 functions, I'm going to show you several organizational charts. Typically, an organization, whether it's for-profit or not-for-profit, is going to have some sort of governing body, which will have a title, Board of Directors, Board of Trustees. Their role is not day-to-day management of the organization. They focus on policy. One of their key policy decisions is going to be selection of an executive director, chief executive officer, or whatever other title it might be, for the senior level day-to-day administrative person in the organization. The board of directors shouldn't be involved in the day-to-day operation. They should leave that to the executive director or whatever other title we're using, and they should focus on policy. That isn't always the case, and it creates a serious complication where the board of directors wants to become involved in day-to-day activities. So that's a key component of governance, defining the role. If you become a senior level manager in an organization, defining your relationship with your board of directors in terms of governance is extremely important. They get to hire and fire you. But they shouldn't be calling, and if you look down at the home care component, there are a group of staff members. One of the members of the board of directors shouldn't be saying, my nephew just graduated from an MPH program. I think that he should be hired to work in the home care function of our organization. And if the governing board member gets into that position, it's extremely complicated for the manager to deal with those issues. So defining that relationship of governance is extremely important. Okay, let's talk about some specific ways we organize healthcare services. There are 2 key terms, again, that come out of management that I want to refer to: line and staff. Line authority is who directs who in an organization. In this example, the director of public health has direct line authority over the 2 associate directors. The director supervises those 2 individuals. It means that the director tells them what tasks they should take on, gets to hire them, and if necessary to discharge them from their jobs, does their annual performance reviews, and so on. In contrast, you have an associate director for patient care. There's a horizontal line to the medical director. That's really a staff function. Typically, the full-time person as associate director for patient care may not be an MD, and the medical director is. The executive assistant to the director is also a staff function. the executive assistant doesn't supervise anybody. They have a clear function in the organization, either as medical director or executive assistant, but they don't have authority to supervise individuals, so they are not line responsibilities. They are staff roles. Here are 4 ways we can organize a health department: by function, geography, client, or purpose. So they can be organized in various ways. Under function, it's what the various units do. We could have a planning department, we can have a communications department, we can have a human resources department, we can have a finance department. Those are organized functionally. Alternatively, we could do it by geography. If the county is very large, we might organize it and say we have 4 units, one for the north part of the county, one for the east division, a 3rd one for the southern part of the county, a 4th one for the western part. We could do it by client, who we serve. We could talk about the director establishing departments for services meeting the needs of children, adolescents, adults, senior citizens. Or we could do it by purpose. The director could organize around specific purposes: well baby services, health promotion, substance abuse. Typically, we're going to see something that's more complicated than that. Here's a department that's a mix of those activities. So in the North Division, which is geographic, we have things defined around the set of clients we have on this chart. Under the South Division, we have the services defined around purpose. And under the East Division, we have services that are defined around, under client again. So what we're doing is saying that we're empowering, as director, the authority of the directors of the North Division, East Division, South Division, and West Division to organize their services in their geographic unit to best meet the needs of the population that they serve. So perhaps if the North Division is primarily urban and the South Division is primarily rural, they may decide there are different strategies to achieve the desired outcomes. So we end up with these mixed models in terms of how the services may be best provided. Or they may simply be based on the prior experience of the supervisors. There's one other model that people frequently have talked about in the past. It's becoming less common currently, which is called matrix organization. In the matrix model, what we have is both horizontal and horizontal and vertical supervision in terms of line authority. As you can see at the top, under the director of the department, we have functional responsibilities under planning, communications, human resources, and finance. If you look at the side, we see them are organized around well baby services, health promotion, substance abuse. In this way, what we can do is see that in the cell which is called well baby services planning, the individuals are working with both the planning department and the well baby service. When we get to the next cell, well baby services, public relations, and communications, they're relating to the people who have expertise in public relations and communications, but still working with the people in well baby services to coordinate their activities across that row of activities. Same thing in regard to resources and well baby and finance and well baby services. The logic makes great sense by bringing people to the table who have greatest expertise related to the functions of a particular unit. The complication is people have more than one boss. That you're working for both the director of well baby services and the director of planning, potentially, if those people have line authority. If they have staff authority of one and line authority of another, it makes it a little less complicated. But I think this is a complex relationship, and as a result, we're seeing less matrix organization now than we may have in the past. Okay, human resources, complex set of policies that must be implemented, things like the expectations related to disabilities, services for populations that we have involved in our services. How do we recruit people? How do we screen them? How do we hire them? As an example, can you, if you're hiring personnel, can you conduct a criminal background check on an applicant without their permission? How are we going to make the best decisions to bring in staff members who are most likely to meet the needs of the organization and the job description we prepare for those individuals? And here's just a sample list that I pulled from a reading that talks about some of the things that we're looking for in recruiting personnel. Obviously, there are individual characteristics, what the individual brings to the table. One of the interesting discussions we've had in recent years is a change in the expectations of the millennial generation compared to the generations that preceded it. Are they different than their excuse me, their predecessors in various jobs? As an example, use of technology may be different. Job characteristics. If we find somebody who's just a wonderful person, how do they fit the job that we're hiring them for? And then finally, the work environment. Some people work better as individuals, some people work better on teams. What are the needs of our organization in terms of organizing the activities to meet our mission for the organization? One quick example, many of you are familiar with McGregor's theory of human motivation. This is an example that people frequently talk about, theory X and theory Y. Other people refer to that as classical and behavioral management. Early in the 20th century, as factories were growing, workers were frequently viewed as simply cogs in the process, that if they didn't do their job, we could hire somebody else to do it. And that the only reason they're doing their jobs, they're motivated by the money that they receive to do the job. They're basically lazy. If we don't stand over them continuously and supervise them, they're not going to do their jobs. They're going to slack off. In the 50s and 60s, we saw this alternative model, theory Y, which is behavioral, that employees are motivated by a variety of things, including wanting to do a good job, that we can trust our employees to do the right thing. More recently, we've talked about management being a variety of characteristics. There are some books that referred to it as theory Z to complement X and Y, others who talked about contingency theory, others that talked about situational management, where these individuals were saying rather than having one best way where we say employees are lazy and we have to make sure they do their jobs, or the alternative that employees are highly motivated and happy employees do a better job than unhappy employees. Things are situational. There's not one best way to manage. Based on the job that we're considering, based on the personality of the individuals holding those jobs, there may be different ways to supervise them. Okay, so let's shift over into some strategic planning. You're familiar with these terms, mission, strategies, and tactics. Those are the means to accomplish specific ends, vision, goals, and objectives. And let me show you an example. Here's what I think is an exceptional way to describe the strategic planning process. There are 4 questions on the left side of the page. First one, where are we now? And this goes back to what we were talking about with systems. We need to collect information about both the external environment and the internal environment, a situational analysis. Some people talk about SWOT analysis, or WATS, strengths, weaknesses, opportunities, threats. And WATS is the same thing, it's just the letters are organized differently. By understanding the environment, we can identify priority issues and challenges. That leads us to the second step, is where should we be going? What are the alternatives? In the same way as policy analysis, we can think about and discuss where we should be going, and that will lead us to development of goal formulation, defining what people typically have in a strategic plan. An explicit statement of vision for the future, a mission statement, goal statements, objectives. Usually a goal will be more general, an objective will be more specific. I think ideally a goal will say, by the following time, by 2016, we will have a measurable result. Infant mortality will be reduced by 5%. And that is a component of the strategy that we'll be seeking to implement, and I'll show you an example in a moment. Third question, how should we get there? It's really great if we can say we want to accomplish something, but how are we going to do it? What are the strategies to reduce infant mortality? If we know what the strategy is, what are the resources that we would need to accomplish that? And the first thing is in terms of personnel, equipment, supplies, and what's driving that is going to be the budget. And we'll talk about the difference in capital and operating budgets in a moment. Then that goes into our day-to-day operations, management information systems to collect information to see how we're doing. We need to do some sort of ongoing evaluation of our performance to do quality improvement. We'll get to that in a moment again. And if we're achieving what we want, that's wonderful, but if we're not getting the outcomes we need or desire, how are we going to adjust them? Are we going to say we're going to change what we're doing to achieve the objective, or are we going to say, well, we just can't accomplish that objective, we're going to lower our expectations? And then finally, as in all of the systems we've talked about, there's feedback, which goes back and you start over again. Some organizations do 3-year strategic plans. Some organizations do 5-year plans. My greatest concern in terms of strategic planning is it requires a lot of time and energy. What happens once the plan is finished? Some places, everybody looks at the plan every week. Other places, there's a loose leaf notebook with 40 pages of the plan, and people put it on a bookshelf and they don't look at it again until it's time to start the next plan. These are just some examples that I pulled off the web of organizations that had plans. In the center, you can see one where there's a bar graph showing one of their goals going from 2010 to 2020. Being more specific about it, here's an ongoing planning activity. You're probably familiar with Healthy People 2020. There was a Healthy People 1990, 2000, 2010. In it, it has a set of goals. These are more general than what I was describing as objectives. Reduce the rate of fetal deaths at 20 or more weeks of gestation. If we reduce the fetal death rate by 1 instance, have we achieved our goal? Yes. Do we really want to be more explicit about it in defining an objective? Some of these are a little more specific, but they're still fairly general. So these would be goal-related rather than explicit objectives in my definition of strategic planning. And here's, again, an example of defining the Healthy People model as a system with goals and objectives, a process to achieve that, and then outcomes with ultimate feedback going back up to the goals. Okay, again, let's switch gears to marketing. People talk about the 5 Ps of marketing or the 4 Ps of marketing. Depending on the people you talk to, they may include all 5 or they may limit it to 4. At the top of my page, I've identified the 5 Ps. The one, if you're only talking about 4, the one that wouldn't be considered as people. So the product, and what we do typically, rather than something you hold in your hand as a product, it tends to be a service. So it could be, rather than a P, it's an S. I don't know how you'd say the 3 P's and an S, though. So typically we talk about the product or service. What are we offering? The second thing is price. How much does it cost? But in addition to that, what are the expenses associated with delivering it? And those things may not only be to the organization, but it may be to the consumer of the service. If your facility is only open from 9 o'clock to 5 o'clock Monday through Friday, for people who are working and are paid on an hourly basis, who need to bring their child in for clinical services, there's a loss of work activity for 3 or 4 hours to visit the facility. So there's an additional cost related to it that could be incorporated into price. The location. Where's the facility located? In terms of public health services, for people who drive, is there an easy way to get there? Is it on a main street? For people who don't drive, is there a bus stop nearby? Do you provide transportation? Is it up a flight of stairs? Are there barriers for access for people who may have disabilities? Promotion. How do people know about the existence of the service you're involved in? Are you going to have a television commercial promoting it? Are you going to hang posters someplace? Are you going to have brochures or word-of-mouth activities? People, who are the people involved in providing the service? Have you hired the best staff possible in regard to these? So as a model, what I've done is I've taken those 10 essential public health services from the wheel we looked at from CDC, and if I was trying to define a set of activities for marketing, I'd look at the product for each of those activities, product or service, the price related to it, and so on, and try to fill in the cells related to all of those activities as the next step in my planning. Beyond the strategic plan, it becomes more operational. Okay, I said we'd get back to finance. Just some simple terminology is probably the key thing, that regardless of the organization, we're going to have sufficient funding to cover the operating costs associated with the organization. How do we effectively manage those resources becomes the critical component of financial management. We can set it up as a system, as we did in the first thing we discussed. But we have some specific terminology that we should share. When we're talking about things, we want to differentiate between costs and charges. What we tend to think about first are charges, the second thing that's there. What is somebody asked to pay? And that might include the surplus revenue to replace equipment in a not-for-profit organization, or the profit that goes to the investors in a for-profit organization. So when I had the oil changed on my car last week, they not only charged me for the time for the mechanic who changed the oil and the cost of the oil and the cost of the oil filter, they had to build additional things into the charge, which were the costs associated with it. The mortgage on the building, the utility bills, the cost of their advertising and marketing activity to promote the service they provide. So frequently people get those two terms mixed up. What's the actual cost to provide the service? If you only charge that sum of money, it's a break-even event. Charges typically have additional fees associated with the organization. Okay, continuing on, we could talk about fixed costs and variable costs. A fixed cost is the same every single week or every single month or every single year. We know it's going to be the same. For anybody who pays rent or owns a house and has a mortgage, we can anticipate what it's going to cost next month. Variable costs change. If you're driving across the country and you're staying at motels, some motels are going to cost more than others. Some are going to be nicer than others, and that may be the factor. In healthcare, the variable costs are going to go up with the increase in demand for services provided. We're seeing an increase in the number of cases of flu in the United States right now. I would think the variable costs associated with treatment of influenza are different this month than they were in October. There's another category of budget that we need to consider, which is capital budgets. Instead of our operating budget, what we're spending money on a day-to-day basis or month-to-month basis, capital budgets are the large, high-value, long-term activities, things that we're going to look at taking over a year. Building a new facility, construction costs, replacing an expensive piece of equipment in a hospital, maybe a CT scanner. In a local health department, maybe it's buying a bus. But we're also going to have a capital budget separate from our operating budget. And the four terms you would want to think about in terms of operating budget: revenue, a forecast of the resources that are coming in; expenses, the costs and charges are going to balance out in terms of revenue and expenses; surplus in the not-for-profits, profit for the investors in the for-profits; and the risk that we always have is a deficit or a loss, that we don't have sufficient money coming in to cover our expenses. Okay, we've already talked about this one. I guess the only other point I want to make is the for-profits and not-for-profits are certainly different than the government public health agencies, which have a different source of funding and a different set of responsibilities. Health informatics, how are we going to manage the amount of information that we are dealing with? One of the current trends that we're seeing more and more is in regard to electronic medical records. How much information are we going to see that is being maintained electronically? Will you have access to it over a portal on the web? I don't know how many of the people participating right now wear a Fitbit or some other personal device to measure information, which is being uploaded to a site. iWatches are supposed to come out later this year. In regard to the ethics and confidentiality we talked about earlier, who has access to that information? What are they going to do about it? What's the security of information in an electronic medical record? Who can share it? Who can see it? Workforce, who's going to be holding the jobs related to public health organizations in the future? What are the credentials they should have? One of the things that the National Board of Public Health Examiners is talking about is a growing number of organizations that, if not requiring CPH certification, are, at least when they announce jobs, indicating a preference for people who hold that credential. So what are the criteria? Is it an academic degree? Is it a professional credential? ASPH, what's now the Association of Schools and Programs in Public Health, was involved in a study that forecasted a shortage of people well-trained to fill jobs in public health by the year 2020. There was a period of time where it didn't seem like that would be the case, that, you know, based on government budgets shrinking, some organizations were actually reducing the number of people involved. We've got a lot of baby boomers, however, who are approaching retirement age or have reached retirement age. And in some cases, those people have postponed retirement because of the uncertainty of the economy. As the economy is improving, are we going to see a large number of people in the current public health workforce who decide it's time to retire? And who's going to replace those? So the ASPH model was talking about 250,000 new opportunities for public health in the public health workforce by the year 2020. What should be the education and training of those individuals? We're seeing, you know, the growth in the number of baccalaureate programs to complement master's degree education and doctoral education in public health. what are we going to expect is the entry-level credentials to fill jobs in public health. Everybody has probably seen that this is public health videos, if not being involved in developing them. What are the opportunities for the graduates of MPH programs? Who's going to recruit them? Let's talk a little bit about the quality of the individuals. One of the things that I think is extremely important, probably almost everybody on the call today has a driver's license. I always think about Dustin Hoffman in the movie Rain Man, where he talks about being a very good driver. Does a driver's license indicate somebody's a good driver? I think it says that they meet the minimum standard to pass the driver's license test. It doesn't mean they're a good driver, it just means they're not a terrible driver. Same thing applies in what we do. Does taking the CPH exam raise the bar for people working in public health? It's a next level up, saying that they've met an additional requirement, they've passed an examination demonstrating competency in public health. So I think that while it doesn't always guarantee absolute excellence, it says that the people who are CPHs have met an additional standard beyond education. And that's important to the workforce. Okay, we see the same thing institutionally. Hospitals have accreditation. Does that mean they're a great hospital? Perhaps not, but it means they meet the minimum standards. So they're not a bad hospital. Same thing has happened more recently. I'm sorry, one other slide before we go on. Even though most hospitals in the United States meet accreditation standards, which are required if they want to receive reimbursement under Medicare and Medicaid, the National Academy of Sciences Institute of Medicine in a report said that there are 44,000 to 98,000 deaths annually from adverse events in hospitals, over 1 million injuries in addition to that. What's adverse events? Mistakes. So what we're talking about is most people fare well in hospitals, but there are negative outcomes as well. There are mistakes that are made. How can we improve those? More recently than hospital accreditation, we've seen the same thing with a growing number of health departments in the United States that are seeking accreditation through the Public Health Accreditation Board. So we're starting to see this trend occurring in public health as well as in other institutional settings. One of the ways that I think we can talk about quality, and this is probably the most common thing, is PDCA, Plan, Do, Check, Act, where it's a continuous process where we implement our planning strategy into the implementation, we evaluate it, and we take specific actions to continue to improve the process. So again, this overlaps with a variety of the things we've been talking about up until this point. One of the things that impresses me, and this is probably less critical to the exam, but I always like to share it, there's something called the Baldrige National Performance Excellence Award. Excuse me, where initially the recognitions in this annual award were in industry and service organizations like Ritz-Carlton hotels. There are a growing number of hospitals that have received this award, and I'm waiting to see the first public health department to be recognized with this very prestigious award. At the center, what it does is it talks about these management functions that define quality. The leadership of the organization has impact on its strategic planning and its stakeholders. Its focus on patients and other customers and markets. On the other side, we talk about the importance of our staff, the Theory X, Theory Y McGregor model, process management, our activities, and how they relate to organizational performance. On the top and bottom, we see again systems components, the external environment, our relationships and the challenges that it presents. And at the bottom, the activities of measurement analysis and knowledge management information systems. So I just think that's an interesting example of a recognition that demonstrates more than meeting a minimum standard. Another one that people frequently talk about is Six Sigma as a process improvement process. What it talks about in industry is reducing mistakes no more than 3.4 defects per million. If we were talking about the fact that in delivery rooms of hospitals, we were going to set a standard where it was okay to drop 3.4, let's round it down and say only drop 3 babies out of every million babies born onto the floor, would that be acceptable? In industry, it's much more acceptable to talk about those numbers. We want to be perfect, but if we said we will have 0 defects in public health, is that possible? Our goal is to minimize it as much as we can. This is a strategy to seek to accomplish that. Quality requires an ongoing commitment. Just because we're doing well this year doesn't mean we'll do equally well or better next year. Arnold Schwarzenegger is certainly an example of that in his life transition. Okay, that wraps up my overview of management. Any questions?
I think we're good. There was a couple people that were having audio problems. It's fine for me. Having any audio problems, just try to dial in using your telephone.
Yeah, it's what we were talking about earlier with the conference call I was on. Hopefully the recorded version will not have that problem, and people can go back if they want to address a specific topic.
Right, but it should be fine otherwise. Thank you.
Okay, I'm sorry for anybody who had any audio problems. So let's wrap up. I've tried to cover as an overview rather than detailed content, a broad overview related to the MPH competencies in health policy and management and the National Board work model. Let's go back to the quiz. I'm going to ask the same 8 questions, see if you answer them the same way or not, and once we go through the 8, we'll talk about the answers. Okay, so the first one, licensure of nurses, is an example of. And we'll just allocate about 5 seconds for each of these. Second one, I hope that's enough time for you. In regard to policy, the third question. The fourth question. Number 5. Number 6. Number 7. And the final one. Okay, and let's look at the answers. I don't know if anybody has changed any of the answers from the first time to the second time. And again, as I said, these aren't questions that were designed for the examination, but these are the sorts of things I would write as questions for the examination. Okay, so licensure of nurses is an example. When we talked about those 4 components, structure, process, outcome, and the external environment as a separate piece. Licensure is a structural element. It's developed through both law and regulation. And it's structural, where it defines the educational expectations, the examination expectations for nurses or other personnel for that matter. Okay, and smallest percentage of U.S. healthcare spending addresses public health services. As you'll recall, there was that pie chart with a 1% slice taken out of it for public health. And if anybody has any questions about these, please type them in and we'll try to talk about them. The Belmont Report, it talks about respect, justice, and beneficence. What we're talking about in this case is the complications of injury, which would be beneficence. Litigation would be a complication of malpractice or negligence. And to be honest, I just ran out of options and I made up assessment of benefits, something you probably wouldn't do on a real exam. The U.S. Constitution empowers detention of contagious individuals. As we looked at in policy, there's a provision in the Constitution that provides for that, which is implemented through law. Paying a monthly flat fee for all medical care needed is a capitated model in contrast to fee-for-service. Health maintenance organizations, you pay a standard fee. Regardless of whether you use services or not, it's the same fee. Shriners Hospital, it's not affiliated with a religious denomination. It's not for-profit, it's not government, which means it's a not-for-profit, non-sectarian organization. By June 2013, there will be a 0.2% reduction in HIV infections is an example of an objective. It's time-specific and it's measurable. If goal had been a choice and it simply said, we'll see a reduction in HIV infections, that might be more relevant as a goal. Budgeting for the monthly restocking of pharmaceutical use in that month addresses variable costs. The reason is we don't know at the beginning of the month. We can estimate it, but we don't know how many pharmaceuticals will be used. If there is an example, if there are a lot of people who have influenza this month, we may be dispensing more medications. So it may vary and go higher in January, and at the end of flu season, it may go down again. Okay, so I hope you did well on those. As this was an overview, I thought I'd share with you a couple possible books that are useful if you want to look into greater detail on any of these topics. And again, you'll have these available as part of the PowerPoint slide. Introduction to Health Services looks at the broad system aspects as its highest priority. Health policy in the United States obviously is a focus on policy making. Principles of Public Health is more focused on public health. And this is in the 4th edition now. I just haven't updated the slide. Healthcare delivery system. This one didn't copy as well. Managing Health Services Organizations and Systems by Longest and Dar is a much more focused management textbook. Is a broad overview book of public health. The Turnock book's probably a short one, easy to review. For management and leadership, this is part of the same series. I should point out that both of these books are paperback. I think they were really designed more for undergraduate education than graduate education, but as a way to do a quick overview, both of them may be very useful to you. So in wrapping up, I wish all of you score well on the examination. I hope you all do extremely well and become CPHs, and that pretty much wraps it up unless we have any other questions.
Dr. Lee, we do have one question. Can you
Sure.
please explain exactly what a preferred provider organization
Oh,
is?
sure. I didn't go
operates?
into that because it's very specific. Preferred provider organizations are another mechanism to organize the payment and delivery of health services. What they typically do is I go to a group of physicians as a payer and say, we'd like to bring you into this process, and we're going to guarantee we have X thousand patients, and they can only go to doctors who are members of the preferred provider organization. If they want us to reimburse for the services, they can only use doctors on our list. And Blue Cross plans around the country frequently do this, so that if you're not on the preferred list, you can't receive reimbursement from Blue Cross for care you provide to patients. Now they go a step further and they say, well, it's going to be a benefit to you as a doctor to participate because you're going to see more patients. And you're not going to have to wait for people to pay. We're going to promptly pay you for everything you do. As a result, in exchange for guaranteeing all of those patients and prompt payment, we're going to do something else. We're going to ask you to take only a 95% payment instead of 100% payment. We want a discount in exchange for referring all these patients to you. A lot of physicians will say, hey, that's great, I'll be happy to do that. What happens at the second year of the plan? The paying organization is going to look at the doctors who are participating and potentially ratchet things down, saying the doctors who are most expensive, the doctors who have patients who only stay in the hospital 3 days, which is our average, are doing great. But we've got 4 doctors who have patients who are, instead of staying that length of time, they're staying 6 days. We don't know what's going on. Let's look at what these doctors are doing that are differently. And I suppose some of them can say, well, it's because I'm so good that I take the most complicated cases. But in other cases, there's something going wrong with their treatment. The PPO saying we are exclusive and preferred may say, next year we're not going to renew your contract unless you come into compliance with the other doctors and shorten your hospital length of stay. Or it may be something related to preventive services to reduce the need for an acute care visit. But the goal of the process is to make it more efficient. I hope that answers the question. It's really hard doing this electronically without voice, so I apologize for that. Any other questions?
I think that's about it. We've got a lot of comments saying thank you very much for your time and for nurturing the future public health professionals. And so we really gratefully appreciate your time and effort. And as I stated before, we will have everything archived on the ASPPH National Board of Public Health Examiners website, as well as all the recorded presentation will be housed on the ASPPH YouTube page, and the link to that is also on the National Board of Public Health Examiners website. And hopefully you gained a lot of knowledge for this session. We do have 4 more sessions. Registration is open on the NBPHE website. Please take a moment to take a look at that and sign up.
Great. Thank you all for your patience listening to me with an ear infection. I don't think I did as well as I normally do. If anybody has any questions, feel free to email me at the University of Georgia, and I'll do my best to answer them.
Wonderful. Thank you, Dr. Lee.
Thank you, guys.
Bye-bye.
Erin, you still there?